Hello, everyone, and welcome to those who are joining. We'll get started with the webinar today. So welcome to the 7th Health Research from Home webinar. For those who are joining for the first time, welcome. And for those who have been to the webinars before, welcome back. If you're new to this, quick intro, Health Research from Home is a research collective that shares best practices so that smartphones and wearable devices can be used to transform patients' lives, particularly those living with long-term health conditions. So my name is Ashna. I'm a PhD student based at the University of Oxford in the Nuffield Department of Medicine, but I'm also affiliated with the Health Data Research UK PhD program for health data science. In terms of research interests, I've got a keen interest in digital technologies in resource-limited settings. So I'm quite interested in this topic. I'd also like to formally introduce Coral Stevenson, who is the project administrator for Health Research from Home and is operating behind the scenes today. So anything you see behind the scenes is all Coral's doing. But before we do get started, it's quick housekeeping rules. So we are recording today's webinar, as you may have heard in the voiceover at the beginning. This recording will be paused during the Q&A, which is the third agenda item. The recording will then be uploaded to the YouTube channel on Friday, and you'll find a link to the YouTube channel in a follow-up email after this webinar. For the Q&A itself, we really encourage you to submit questions in the Q&A box throughout the webinar, so you can do this as speakers are talking. You can submit questions for the Q&A at any time. Given the number of people who have joined today, we're really excited to see this level of interest, but everyone's mics have been muted for the presentation. So the host will unmute anyone who would like to ask a question during the Q&A. And as always, there's a chat function here in Zoom at the bottom toolbar. So feel free to use the chat box at any point to interact with each other or ask the host for technical support. So with that, I will go ahead and introduce the first of two speakers we have today in the wonderful lineup. Speaker is John Ainsworth, who is a professor of health and informatics at the University of Manchester, and is also the director of the Center for Health Informatics and Health E-Research Center. John works at the intersection of information technology and healthcare research, focusing on applying information technology to improving healthcare outcomes. So without further ado, I will pass it over to John. Thank you.
Thank you very much indeed. I'll just share my screen. And somebody give me a thumbs up if that's all okay. Perfect, thank you.
Looks good.
All right. So thanks very much for inviting me. Excuse me. Today to talk about digital phenotyping in mental health. I also have a couple of roles as well, in that I'm also the co-director of the Mental Health Translational Research Collaboration, which is a national network, and I'm also the co-lead for the data and digital theme in the mental health mission, of which I'll talk about more later. So across our two talks today, both mine and James, this is broadly what we're going to cover. Going to look at the opportunities and challenges for digital phenotyping in mental health. I'm going to talk about two exemplar projects, Connect, which is a large national study, and the mental health mission that I already mentioned. And then James is going to talk more about how we might formalise our approach to digital phenotyping in mental health using ontologies. So I'll get started. This is a really helpful explanatory figure from David Moore that was published in 2017. And what we're really interested in mental health is trying to understand your clinical state and how that changes. And there are a number of high-level behavioural markers that may change that indicate how your clinical state is changing. For example, sleep disruption, depressed mood, social avoidance. And these are the things that we would really like to measure as a way of understanding the progression of somebody's disorder or illness. And as you can see from this, there are different ways potentially you can construct these from lower layer sensors. For example, location-based, GPS, Wi-Fi, how you interact with your phone, screen on and off, the number of messages you send and to who you send them and the frequency of which you send them, ambient light, microphone, and all of these can potentially be combined into what's termed the low-level features. So we can work out which locations you visit frequently. We can understand when you go to bed, when you wake up. We can look at metadata about your speech patterns. And all of these potentially could lead up to these high-level behavioural markers. So this really illustrates very nicely the landscape that we're in and how we're trying to get from these low-layer sensors to these high-level behavioural markers and use those and patterns of their change to understand clinical states and potentially, for example, predict when you might deteriorate or relapse into psychosis. So with that, I'm going to start talking about the CONNECT study. And you can go and see the website there, connectdigitalstudy.com. So this is a large national study that's been funded by the Welsh Government and led through the University of Manchester. It's a prospective cohort study, and we are basically building or have built a large platform for the collection of digital phenotype data, both actively collected through participants responding to questionnaires, but also passive data measured from sensors on smartphones and also wearable devices. And the objective of the Wellcome Trust Connect study is to develop and validate risk prediction algorithms to estimate the risk of relapse into psychosis. A second objective is to try and balance the combination of active and passive symptom monitoring so that we actually minimize the amount of times we ask a participant to enter and self-report data. And in order to do this, we have a cohort of 1,100 people who previously had psychosis across the UK, prospective cohort study, so there's no intervention. And we will produce a very large data set of these data items collected over a 12-month period. We will then also be able to label this data set with episodes of relapse that we'll be able to extract through electronic health records and case notes. So, as I said, it's a study that runs throughout the UK. So it's centred on Manchester, and the PI is Professor Sandra Bucci, my colleague. And within Manchester, we have teams that are responsible for managing the data and the data collection, for doing the statistical analysis and doing machine learning. We then have, in addition to the recruitment sites in Manchester, we then have 5 other sites. We have the University of Glasgow, led by Professor Andrew Gumley, Cardiff University, led by Professor James Walters, Sussex, led by Professor Cathy Greenwood, King's College London, led by Professor Till Wykes, and University of Edinburgh, led by Professor Mateusz Schwerner. So we have good coverage across the whole of the UK, different mix of both some urban and rural populations from which we will be recruiting. So the study design, and this is the individual participant's view, it is a 12-month period, which is a long time for people with quite severe mental health conditions to engage with this kind of monitoring. And so one of the things we have focused on is monthly check-in phone calls, technical troubleshooting, and study check-in, which actually happens quite a lot during the first month, but then occurs monthly beyond that. We also have requesting them to do active symptom monitoring 3 times a week, which includes self-report data on psychotic symptoms, mood symptoms, fear of recurrence of relapse, and additional contextual information. We have a baseline assessment, and then we have clinical assessments at 3, 6, 9, and 12 months. So we are getting an enormous amount of data on these participants from both their wearable, from their self-report, and also from the clinical assessments that we'll do as well. I should also just say as well, all the way through this project, we have drawn very heavily on our LEAP, our Lived Experience Advisory Panel, right from the very start in the design of the project, and then consulting on many different things as they occur through the project, such as, for example, one we've done very recently is at the end of the 12-month period, we give participants a summary of their data collected over that 12-month period, and that was co-designed with the LEAP. In terms of progress of the study, so we are now just at the point where our first participants will complete their first 1 year of data, and we're continuing recruiting, and we'll do for another couple of years probably to build up that cohort of 1,100. So I mentioned active symptom monitoring quite a lot. So we've designed specifically for this program the Connect app, through which all these active symptom monitoring questionnaires are notified, presented for participants to fill in. They mostly consist of responses on a Likert scale between 1 and 7, and you can see an example there. One of the questions I felt there is little point in trying. So we have a battery of these questions, which we previously designed in previous studies. And so that gives us the active symptom monitoring data. Also embedded in the app is the software that collects data from the sensors on the phone and also connects to the wearables to collect that data as well. And so you might ask, what information are we collecting via the wearables? There is a little bit of overlap as well in what we collect, and so you can see all the information we gather from the smartphone there. I suspect many of that will be familiar to you. And then from the wearable, these are mostly physiological measurements, such as heart rate and heart rate variability, skin temperature, whether it's actually being worn on the wrist or not, and things like step counts as well. And I should just say as well that within the Connect study, we've actually given people choices about the technology they can use. So if they want to use their own phone, that's fine. We install the software on their phone. If they would like a study phone, we give them a study phone, so we give them an Android phone. Then for the wearables, there's actually a choice there as well. So we identified some wearables that we were interested in using in the Connect study. One was a Fitbit tracker, one was an Apple Watch, and the other was a Samsung Watch. Now, the way we do this is that if you have an Apple phone, an iPhone, you can choose either the Fitbit or the Apple Watch. And if you have an Android a smartphone, you can choose either the Fitbit or the Android smartwatch. So that's how we run the study. I mentioned before about our lived experience advisory panel, and just to give you a feel for the depth of involvement in this, we've also co-designed with them the app and how that functions and how that works. So very much taking that user-centered design approach. Because the length of this study is really long, 12 months, particularly for this group of participants, we also co-designed some things that we hope will improve engagement, such as every time you finish entering your active symptom monitoring data, you'll get a fun fact of inspiring quotes. We've used streaks and badges of how often you respond and how you keep those streaks going as a mechanism. There's a study newsletter. As I mentioned, we have the drop-in sessions and phone calls. And we also included some personalization features in there. One thing that came out really strongly, actually, was in terms of accessibility features and actually having a dark mode for the app and being able to read aloud the text as well that's displayed on the screen. So again, our lived experience advisory panel, very, very key to this programme. And we've worked in conjunction with the mental health charity McPin to actually develop these materials and run the lived experience advisory panel. So one of the things we were also asked to do by our funders at the start of this was, I said we have 3 wearables. Well, actually, the reason we have 3 wearables is because we wanted, and our funder requested, that we actually pilot the wearables and to see what the preference was for the different wearables and which perform best. And so we have this embedded pilot study inside Connect. We have some very specific research questions that would help us choose and decide which of the 3 wearables, the Fitbit, the Samsung smartwatch, or the Apple Watch, we should use. And these 3 questions were, given that free choice that I mentioned, which wearable device did most participants choose to use? Research question 2, which wearable device is most acceptable to participants after they've used it? And which wearable device provided the highest quality data over the pilot study follow-up period? So this is very, very recent results that are not yet published yet, but I will give you a little flavour of one of these research questions, which is research question 2. And so we used a wearable device satisfaction questionnaire, which consists of 29 questions, grouped into 6 groups: ease of use, functionality and practicality, satisfaction with the device app, smartphone, and physical activity. So we have 71 participants completed this wearable device satisfaction questionnaire at their 3-month follow-up. We also looked at the number of people in each of the 3 wearable device groups who responded positively to each question. So before I move on to talking about the mental health mission, the decision we reached in terms of which wearable device should we use, well, we found for research question 1, which wearable device do people pick, that it was quite evenly spread. There were some interesting demographic that factored into and influenced the choice. In terms of the satisfaction questionnaire, it was fairly evenly split. In terms of the data that we received from the devices, we actually found we got better, more reliable data, more consistent data from the Fitbit. And then we also were able to get some quite unique data through the Apple Watch, because we have full access to a sensor kit that Apple made available to us when we applied. So we are actually now in the Connect study, keeping in there the Fitbit device and the Apple Watch going forwards. So I'll just talk a little bit now about the mental health mission. So the mental health mission is a large infrastructure project funded through the Office for Life Sciences and also the National Institute for Health Research. It again cuts across the entire UK, and the aim of it is to build infrastructure to enable more rapid evaluation and development of new treatments for mental health, and a lot of those may of course be digital health treatments as well. So I actually co-lead the data and digital theme of the mental health mission with my colleague Professor Anne John from Swansea. And a lot of what we're trying to do here is to bring together a lot of the landscape in terms of mental health and that infrastructure. So a lot of what we do is around collaboration and implementation across the mental health mission, because if you look across the different themes, such as children and young people's mental health, early psychosis, mood disorders, they all have strong data and digital components. And that's what we do in terms of implementation and collaboration. Second work package is around informatics for trials and electronic health records. So a lot of this is to do with how we can actually find participants for trials from electronic health records, and involves a lot of phenotyping in terms of understanding the particular code sets that you might need from electronic health records, and also natural language processing, because a lot of data for mental health is actually narrative free text data. So actually extracting meaning from that and understanding and creating those phenotypes is a big part of it. And then we have a work package on person-generated health data that I run with Professor Richard Dobson at KCL. And we're here really looking at how we can bring a bit of order to digital phenotyping using patient-generated health data, so that we can move towards getting repeatable measurements from sensors, smartphones, wearables, so we can start to use those in outcomes in trials. And I think this is very timely as well. So very recently, a report was published by our Wellcome Trust that funded it around how we use sensor-based digital health technologies for mental health research and clinical practice, and actually what needs to happen within the field to make this happen. And this also builds on previous workshops that my colleagues in the mental health missions have been involved in. And I think there are three take-home items from this report that align very well to what we're doing in the mental health mission, one of which is standardization. So how can we create core data elements and map these to individual sensors and items of data coming from smartphones? How can we build infrastructure that enables us to routinely collect this data that's interoperable, so it works into clinical systems, and we can leverage at lower cost? And then finally, ontologies. So if I can make an analogy here between what was happening in genetics, genomics, about 20 years later, their field was in a similar position, where they were getting large volumes of data, people were interpreting it in their own way, and there was a complete lack of standardization. And what this led to was the development of ontologies, such as gene ontology, that actually started to standardize the field. And I think that's where we're at now in terms of sensor-based digital health technologies and digital phenotyping in mental health. And with that, I should have set James up nicely for his talk. So I will end there. Thank you very much.
Thank you, John, for a wonderful presentation. I'll just pass it over to James Cunningham now, who is a research fellow also at the University of Manchester. And his research includes work on data management, sharing, and stewardship. So over to you, James. Thank you.
Thank you. So there we go. I should be sharing now. Yeah, so thank you for that introduction. Yeah, so as John said, today I'm going to be talking about the role of ontologies in digital phenotyping and how they can help us structure and reason about health data from wearable devices and smartphones. So this is in the context of the work we've been doing in both the Connect and mental health missions. So when we work with health data sets, a lot of our effort goes into organizing and interpreting the types of data that we're working with before we go on to process and study it. And our goal here is to show how an ontology-based approach to this organization can help us make sense of this kind of complex and multi-source, multifaceted data. So taking a slight step back again, digital phenotyping is the process of using data from digital devices, smartphones, wearables, to infer measurable behavioral and physiological patterns. So digital phenotype represents these inferred patterns and can provide us with insights into an individual's health, well-being, or mental state. So while we've got a potential wealth of information coming from this digital phenotyping, making sense of that data, understanding what it means, ensuring consistency across different studies, and reasoning about the data, importantly, can be quite challenging. And ontologies provide us with a structured way to represent data, to link related concepts within that data together, and to provide meaningful insights into what that data is telling us. So what is an ontology? So when we're working with data, we often label and categorize it to make sense of what it is we're measuring, what it is we're recording. And whilst this labeling by itself helps us organize information, we can go a step further and begin to define how different concepts relate to each other and what they mean in terms of each other. So an ontology is a structured way to represent data, defining not just categories, but also their relationships between each other. It provides a formal meaning to the terms we use and enforces logical connections between them. So in practical terms, I guess this means that we can define digital phenotyping concepts and the concepts that we talk about when we're doing digital phenotyping, such as raw data, features, and phenotypes, and specify how they link and link together. So taking this structured approach enables us to reason, to integrate across heterogeneous data sets, and to have the ability to do more powerful analysis on the data that we're looking at. So as a kind of analogy, if you think of an address book, it's something that provides us with a list of places, a list of addresses. This is the equivalent to kind of labeling data, but what we really want is a map that shows us where these places are and how they connect to each other. So an ontology does this for data. It provides a map of how raw data points link together and lead us to meaningful insights. So yeah, why this matters? It provides us with three kind of things: clarity, interoperability, and reasoning. So it ensures clarity. So step count, screen time, sleep duration. We can make sure they always mean the same thing when we talk about them. When we describe data as describing screen time in two different places, we can make sure that we're talking about the same thing. And leading from this, it improves interoperability. It allows us to connect data from different devices and different studies in a meaningful way. And it enables reasoning. So it allows us to infer new insights, like linking movement patterns to mental health indicators, for example. So ontologies aren't just a kind of theoretical thing. They are widely used in biological medical sciences, as John mentioned. The gene ontology for genetics structures biological processes, cellular components, molecular functions in such a way that researchers can classify genes consistently, and that helps us kind of give automated reasoning. If a gene is associated with a process like cell growth, it can be linked to higher level categories like development without manually encoding every kind of relationship that it's in there. And in, excuse me. And in the medical world, we've got SNOMED CT, which is a medical ontology that standardizes clinical terminology across different healthcare systems. So, for example, terms like if you have myocardial infarction and heart attack, we can know that they're talking about the same thing, the same clinical concept. So this gives us these ontologies are used to give key benefits to describing data. They give us standardization, they give us reasoning power, and they give us the ability to discover new knowledge. So why ontologies in digital phenotyping? So digital phenotyping data comes from many sources. It comes from smartphones, wearables, surveys, each of them potentially across each other and within different studies using different formats and different definitions. And there's no universally accepted way to represent data or to derive features like step count, sleep patterns, or sociability across studies. So without standardization, it's difficult to compare results, to integrate data sets, or to scale analysis across different data sets and different studies. So the solution that we're approaching this problem with is to use ontologies. So it gives us, as I say, a formalized structure for describing features, describing phenotypes, what they mean and how they relate to each other. For example, we could talk about screen usage and make sure that always refers to the same concept, regardless of whether it's measured from an iPhone, an Android, a third-party app, or whether it's derived from some other data or some other measure. On top of this, it gives us the ability to infer things. We can link Bluetooth proximity, so how many Bluetooth devices there are within range of the device you're using at a certain time, and we can infer things like how what kind of sociability rating or score that we can assign to the person using this device. And then again, between different data sets, different studies, we can make sure that heterogeneous data is represented in a consistent and shared way. So within Connect and the mental health mission, we began designing and putting together an ontology to represent these concepts to do with digital phenotyping. So our ontology describes a set of core components that we can use to label and structure data with. So we've got data sources. This is where data is coming from. Things like smartphones, wearables, passive sensing platforms, each providing different types of raw data. Then we move on to the raw data, which is describing things like direct sensor outputs. So the readings from accelerometers, GPS coordinates, heart rate measures, logs of screen usage. So at this stage, data is often unstructured and requires pre-processing before it can be useful. We can then describe processed features. So this is basic structured metrics derived from the raw data. So these are kind of straightforward transformations. So we can describe step count and how step count is derived from accelerometer data. We can describe things like call frequency derived from phone logs, or total screen time from different app usage records. So these features are more structured, but still fairly close to the raw data. Then we can describe things like derived features. So these are kind of behavioral or physiological markers that are inferred from the processed features. So we start interpreting, at this stage, we're starting to interpret behavior. How active is a person? How regular is their sleep? How socially engaged are they? For example, physical activity levels are derived from a combination of step count and heart rate. So we begin to put the processed features together to derive more higher level data. And then at the kind of top level of what we're describing, we've got the digital phenotypes themselves. These are high level constructs reflecting, for example, mental health states. So at the highest level, we infer meaningful health indicators like depression risk, anxiety risk, or social withdrawal. And these are not directly measured, but they're derived by analysing patterns across multiple features. So each layer of the ontology here is kind of building on the previous one, allowing us to trace a clear path from raw sensor data at the bottom to meaningful health insights at the top, all the while kind of ensuring consistency across studies and making it possible to apply automated reasoning. So on top of these kind of core concepts that we've got within the ontology, we can begin to describe inference rules as well. These are rules and logical connections within the data that describe how raw data transforms into features and ultimately phenotypes. So the ontology encodes rules that describe how raw data is processed into structured features and how these features combine into higher level phenotypes. For example, heart rate variability can be transformed into a stress measure, which can then contribute to aspects of a fatigue related phenotype. We've got dependencies between features. So some phenotypes can be inferred in multiple ways. For example, sleep quality can be derived directly from sleep tracking or indirectly from a combination of phone usage and step count patterns. For example, if you stop using your phone, stop walking about, and it's nighttime, we can infer that sleep might be happening. Data is often incomplete, so one data set might have direct sleep tracking, another only has step count and phone usage. But by structuring data within an ontology, we can begin to talk about the same things, even though we've got different raw data underlying it. And then we can distinguish between directly measured, computed, and inferred information. So we can talk about on the lower levels things like Bluetooth proximity, higher level social interaction score, and then at the top level kind of social withdrawal risks, for example. And not all data is collected in the same way. So some features come directly from sensors, others are derived through statistical models, and some are inferred based on behavioral patterns. And all these things we can combine within the same structure of data. So as a kind of quick example, we can model something like sociability. So we start with the raw data sources that provide relevant signals, so Bluetooth proximity, phone communication patterns, and movement data. So the Bluetooth proximity captures the number of devices nearby. Phone calls and messages reflect how frequently the participant using this device is communicating, and then movement patterns derived from things like from clustering GPS locations can help us assess mobility and engagement within different social environments. And then the ontology reasoning, the reasoning ability of the ontology, defines how these raw inputs translate into behavioral features and phenotypes. So for example, if someone consistently has many nearby Bluetooth devices and frequently makes phone calls, it would suggest high sociability. And on the other hand, low movement combined with infrequent communication may indicate potential social withdrawal. So it's these kind of rules that allow us to reason about behavioral states, even when some of the direct measurements of these things are missing or not available in the data. So other things that structuring data within ontology can do is allow us to ask questions of the data as a whole. So we can ask questions like which data set provides and which data sets that we've got provide information that can be used to infer social withdrawal. What kind of transformations are needed to turn raw features into a phenotype? How different data sources combine in different ways to provide the same information? What the minimum set of features we need from data might be if we want to capture certain phenotypes, and what processing steps are needed and are available to align the data from different devices. And then the kind of the magical feature of ontologies is their reasoning power. As applied to digital phenotyping, it shows how we can infer relationships that allow us to extract meaningful insights even when direct measurements are unavailable. So we can substitute features. If we can talk about data and say that if we have a data set without sleep tracking, then as long as we've got phone usage, step count, and screen activity, we can talk about the same thing. We can describe behavioral patterns, so reduced social interaction, as I say, irregular sleep can infer depression risk, and then we can map on established mental health models that allow us to talk about that. If a data set lacks mobility tracking but includes Bluetooth proximity and app usage, we can infer social and physical activities levels indirectly. And then we can do stepwise reasoning. We can say that heart rate variability contributes to stress level computation, which then informs fatigue-related phenotypes. So we get all these things as part of the way in which we structure and organize data through an ontology. So just to kind of summarize everything, ontologies bring structure, inference, and standardization to digital phenotyping. A well-designed ontology, which hopefully what we're approaching, can link raw data to meaningful mental health insights in a way that just labeling that data doesn't do. And by taking this approach in the same way that they did 20 years ago with genetics and the gene ontology, we can begin to enhance reproducibility and interoperability between largely heterogeneous data sets. And finally, this work it is ongoing, and we're very interested in anybody who feels they can contribute either on the kind of theoretical knowledge level or in terms of insights into their own data or data sets they're working with. So we're happy, both of us, to be contacted to talk about some of this work we're doing. So we're looking for expressions of interest and working out ways in which we can involve the wider community and contributing to this work. Thank you.
Thank you so much, James. Thank you for a wonderful presentation. I will move on to the next little bit, which is a driver project update. So for those who may not know, Health Research from Home is running 2 cutting-edge research projects that will pioneer successful linkage of smartphone and wearable data to existing research data banks. So today we have Nathan Cheetham, who's a senior postdoctoral scientist at King's College London, presenting on linking digital patient-generated health data with NHS data as part of the long-term COVID outcomes project update. So over to you, Nathan. Thank you.
Thanks. Cool. Thanks for the intro. Yeah, so I'm going to be giving an update on the second driver project, which is about the long-term effects of long COVID on health more generally through this data linkage project. So as a quick recap, long COVID is referring to when people are having long-term and ongoing symptoms after having a COVID infection. And this has affected millions of people in the UK and around the world, with the latest estimates within England and Scotland being around 1.5 million people was living with symptoms that were affecting their daily function. That was over a year ago now, in last winter's estimates. So this is kind of a long-term issue for a lot of people still, even as we kind of are approaching this 5 year. It's 5 years since the start of the pandemic in the UK. And so what we want to know is, what are the long-term effects on health more broadly for people that have had or are living with long COVID? And I guess the question within the context of this program is, what can we gain from linking together these different data sources that we have? So we have a smartphone app data that's been collected remotely, where people have logged their symptoms at the time that they had them. And we combine that with survey data collected later on, and now in this project with healthcare record data, to look at what this can tell, what the remote data can tell us about health outcomes. So a big part of this project is the linkage itself with healthcare data. And for this, we're combining our COVID symptom study biobank data, which is the name of our study, with the UK Longitudinal Linkage Collaboration, or UK LLC. And this is a platform that's been set up over the last few years as a way for population studies in the UK to link with administrative data sets such as NHS data and other data sources as well, like education. And I think they're in the process of getting tax records and other broader data sets as well. And so I spoke about this in the December webinar. I'm not going to go into details, but we're kind of going through this onboarding process, which has lots of different milestones and stages. And I was just going to cover where we're up to now. So back in December, we were kind of at early stages. We'd had some positive discussions with the LLC, and we were kind of starting to go through the process. And now we've moved further through the process. And I just want to kind of give an insight into what that means in practice, what it looks like, in case other people are interested in using this platform in the future. So what we did is we sent our participant materials to a panel from the UK LLC to review, to see if it kind of is compatible with how they work, and suggest any changes that they'd like us to make before being able to join. So the first thing that they identified was about our research purpose or remit. The remit of our study has always been focused on COVID-19 quite, I guess, narrowly, in that we want to understand what the effect of COVID-19, specifically the illness, is on people's health. Whereas the LLC has been recently kind of broadened its remit to look at any research that can be done for the public good. So they gave us kind of two options. If we want to kind of have a broader remit, then we would have to reconsent our participants and change our ethics to reflect that, or we could kind of continue within our original remit, but the research that we did using the LLC would have to be restricted to that narrower focus, and that's the option that we're going to go with, because that's our intention anyway. We're happy with that remit, and that matches what we want to do with this project. So we got some good news that we have provisional approval to join, but they want us to do a few things around communications with participants, which we are in the process of doing. So we initially said to participants that we were going to link with healthcare records using the Open Safely platform. That was our initial intention. Unfortunately, it didn't work out, and we decided to go with the LLC instead. But we need to make that explicit with participants, with emails and newsletters, and also to offer a way to opt out easily if people no longer want to link with the link with like NHS data. So that's what we're doing at the moment. We're changing some of the content on our website and our privacy notice to reflect that, and we're drafting newsletters to send to everyone, all of our participants, this month. And we've developed just a simple opt-out process that people can do themselves without the need to kind of have individual email chains, which can be kind of time consuming for both participants and for the team that run our study. And we're looking at this as kind of an opportunity to re-engage with participants, especially as we approaching this 5-year kind of anniversary of the start of the COVID pandemic in the UK. And we're going to make a summary of all the research, all the work that participants have done to date, and remind everyone of kind of the impacts of that, hopefully to kind of re-enthuse people, and I guess reduce the opt-outs, so people were still happy to consent with this project. Then once we've done that, we're going to just basically share that with the LLC team, who are just going to double check that, and then we can move on to the next phase, which is looking at the kind of more legal side of things, the contracts, and eventually the data, where we can get into the platform and start working with the data, which is the bit we're looking forward to the most. So hopefully next time I give an update in a few months, we'll be talking more about the analysis in more detail, and just kind of give a preview of some of the challenges, I guess, of this project analytically. Is kind of, we're working with lots of different, with different complex data sets. So this remote smartphone app collected data we have is this time series data of symptoms, which is kind of covering a wide range of symptoms, and everyone has a different kind of reporting pattern. And how do we process that and interpret it in a way that makes sense to understand people's symptoms, and then how do we make sense and use the electronic healthcare records data, which also has this kind of these ontological coding systems. What codes do we use? And we want to do this as openly as possible, and so we're kind of following some of the the things that have already been set up, such as open code lists, which is used with the Open Safely platform. Yeah, and I guess trying to get away from this black box kind of working where it's not clear exactly what we're doing, but yeah, that's the plan. So that's it for me, and yeah, thanks for listening.
Thank you, Nathan, for that really informative presentation. We look forward to future updates on this as well. I will just share some last sort of announcements here. First, to announce the next Health Research from Home Hackathon event. So applications are now open for this. We are inviting early career researchers from an academic or industry background specializing in health data research to take part in this 3-day hackathon event. So during this hackathon, you'll work in small groups to address 2 challenges in the field of tracked daily symptoms for people living with long-term health conditions. So you'll specifically design and test innovative approaches to simulate and predict pain dynamics, incorporating real-world challenges such as treatment effects, variability in symptoms, and constraints of sampling frequency. So it's a really unique opportunity to network and collaborate with experts, apply your research to real-world challenges, and contribute to the future of health research. So we encourage you to join. This is taking place on the 7th to 9th of May at the University of Manchester, and a £50 registration fee applies. So you can apply now via the QR code on the slide or via a link that will be sent to you after this event. We also want to make you aware of the next webinar. The 8th Health Research from Home webinar will take place on the 7th of May at 1 p.m. So in this webinar, we will welcome Nadeem Sarwar and Scott Small from Novo Nordisk to speak on the topic of their Transformational Prevention Unit mission. So you can register now, again, using either the QR code here or via a link that will follow in a follow-up email. Now, lastly, we want to make you aware of the Health Research from Home clinics. So we recognize that conducting research using patient-generated health data can be difficult and want to help the community to conduct more research in the future. Our clinics are an opportunity to receive one-on-one advice with experts in their fields to help you develop your own research using smartphones and wearables. The first kind of clinics are information governance clinics. So these allow you to book one-on-one hour-long meetings with an information governance expert. So within this 1-hour time slot with the expert, you will get help to identify and understand information governance issues related to your planned activities and how you might go about resolving these issues. These clinics will be held every second Wednesday of the month. So you can book via a link that will be sent in a follow-up email. To note, there are 2 other kinds of clinics, technology clinics and patient and public engagement and involvement, or PPIE clinics. These guys are coming soon, so stay tuned for this. And lastly, we have some resources available on our website through this link. We invite you to suggest, to use these resources, but also suggest ideal future health research from home webinar topics in a poll that should be appearing on your screen about now. So please suggest topics for future webinars before you leave. We really value your feedback and want to make these webinars as useful and as interesting to you. So we also invite you to become a part of this community by accessing the resources on GitHub, the Health Research from Home website, or LinkedIn, either through the QR codes on the screen, or again, check out the email that will be sent as a follow-up for this webinar. But yeah, that's it from us. We really thank you for joining us today. A huge round of applause again for the speakers, and thanks again to Coral for orchestrating all the behind the scenes activities. So thank you for joining, and we'll see you next time.